you for having me. I'm excited to be here and share with you today. I do have slides, so I'm going to share my screen, and there's a little video in there. So let's cross our fingers. So I am LaToshia Rouse, certified birth doula, and I run Birth Sisters Doula Services. I also am a consultant with PFE Consultant Services, where I consult with hospital systems and sometimes individual hospitals on patient engagement. I say that these two businesses came out of my story because they did. And the whole meaning of it is to improve maternal and infant health, one person or one organization at a time. So I'll tell you a little more. So I have an 11-year-old son and triplets that are 8 years old. The triplets are 26 weekers. They were born super early, and they have been just on a ride their whole journey. So I'll tell you how it starts. I was at home, and they're all around me, so you can hear doors closing. I just sent them out. So I was at home with them, and I was really tired that day. I was about 26 weeks, and I decided that I had to go to the bathroom. So I went to the bathroom, and while I was there, I heard a voice coming out of my bathroom. It sounded like someone was in there. It was very clear and very strong, so strong that I pulled back my shower curtain to look. And when I looked, there was nothing there. And I thought, oh my goodness. The voice said, don't worry, I've got you. And I knew what it was. So I was going to leave out of the bathroom, got done, leave out of the bathroom. And I was going to go and call my best friend to tell her what had happened. And as I stood up, my water broke. And at that point, like I said, I'm 26 weeks. My water's breaking. My mother was there with me, and my 3-year-old at the time was there. My husband was at work. So I called and told my mother my water broke, and she's like, how do you know? And I said, I just know. And I told my husband, and he was on his way home to meet me. Called the hospital, and they said, come to the hospital. You're not having contractions. You could be here for weeks. It may just mean that, your water broke, but you're not actually gonna go into labor. So I did just that. We all went to the hospital, kind of got me checked in, and they started giving me medicine to, if they did come, to help with their lungs and their brain development. And so I was there. That was on a Tuesday. Did all that, and they said, you're not having contractions. You can start moving around. So I was able to get up and go, take a shower, go to the bathroom if I needed to, walk around the room. No concerns. This is gonna be where I live for a while. And on Friday morning, what happened was they were giving me a laxative. You're not supposed to give pregnant women laxatives, in case no one knows, because it can thin your cervix and cause you to go into labor. So I told the nurse, I was like, these laxatives you're giving me are making me cramp. And she said, oh, don't take them anymore. And I said, okay, fine. So she's going out to get ready for her shift change. And as she does go out, I have to go to the bathroom. Some of you know what that means. So I go to the bathroom. My nurse had just walked out. And as she did, I felt something was different. And so I reached down and I felt my daughter's head. And when I felt her head, the contractions started hitting very strongly. And once they did, I pushed 3 times and I caught my daughter in the hospital bathroom. And I pulled the chain so that the nurse could come back in the room. And when she did come back, she just stood there and she almost didn't know what to do. And so I said, baby, she ran out of the room and brought the whole hospital back. And they said, they took that baby, got me on a bed, and they said, we're going to have the C-section we talked about. And I said, okay. So we get into the operating room, and they said, second baby's down, push. And I was trying to figure out how to push, but laying flat on the operating table meant that I couldn't find my muscles the way I could when I was standing. And it also meant that I was kind of tired at that point. So I remember saying, can someone hold my legs? And I heard a voice say to me, you hold your own legs. And I said, I didn't say anything. I just did it. I couldn't use my energy towards that at the time. It was so much going on. I was trying to avoid the C-section they told me I had to have. And so I kept working with it, figured it out. Second baby's out. Third baby wasn't down. And so the doctor, in a moment, decided to go in. So he reaches in and turns the baby and brings it down to the exit. And then I pushed one time and my third baby came out. No pain medicine at all during that whole process. And that was never my plan. I had planned to have every kind of pain medicine possible because that's what I knew. And I just could not imagine having, 3 babies any other way. So then they're 26 weeks, 6 days at this point. They go to the NICU. During the NICU stay, as you can see one of the pictures here, it was turbulent. It was a roller coaster. It's a schizophrenic roller coaster, as I do tell people, because you think you're over a hurdle and then another one presents. But the girls were there 2.5 months. My son was there 4.5 months. And in that picture, he was hooked on everything they had to give him. And I was told, we don't know. We don't know if he's going to pull through this. We don't know what's going to happen. It's all up to him. And I took a picture because I wanted to remember that day. Most people don't take pictures of those days, but I wanted to remember because I knew he was going to pull through. Something in me said, this is really scary, but this kid is going to be okay. And he has been. You also see pictures of us. That picture with me in the red shirt was the first time I got to hold all 3. The whole team was back together again. Then you'll see, and around that time, with me in that red shirt, my husband had gone away for work, and I called 911 because I was bleeding. And when they came to get me, after I called them, my whole bedroom, bathroom, it looked like a murder scene. And when they came and get me, I had changed the bath towel that I was using to contain the blood. So I was on my second bath towel. And there was so much blood in my bed when I woke up, and thank God I woke up, I hit the bed with my hand and the blood splattered, like in a queen size mattress that was, it was that much blood. So I was trying to contain it. I get to the front of my home in my living room, and the paramedics came and they started asking me questions. They wanted to know, what did I take? They wanted to know, what had I been doing? They wanted to know, it was like, what did you do to cause this? What are you, just information that to me made no sense. I'm thankful that I got there. So then they were like, can you stand up? And I'm like, no, I can't stand up. They were like, yes, you can. And so they lift me to stand, and I fell. And even before that, I asked them for water because I'm like, I need some water. I need something. I'm going to pass out. And they were like, no, you can't have water. You need an IV. So then they started with the can you stand? And once I fell, they took me out and got me in the ambulance. And when they gave me the IV, it was almost like the lights got brighter. Everything around me came bright, and I didn't even know they were dim. So that was, it's a weird feeling because you don't know I didn't know how much longer I could have stayed that way. but you're glad to see everything brighten up because you're like, oh, I'm still here. And so I went to the hospital. I had to wait. That was around 3 in the morning when I called them. I didn't have my surgery until 11 o'clock the next night. In that hospital, waiting to be in surgery because my case seemed to be less immediate than other people. So I had to wait to get my surgery. So around 11 o'clock that following night, I was able to get that and get back home to start going to the hospital to see these babies and taking care of my older one. And I tell that because people look at them now at 8 years old and they don't know any of that stuff happened. You know, these guys have done well. I've had to fight for medical care for them. I've had to really, really be on top of whatever concerns I've had and making sure they were seeing the right people. And it paid off. And so that is what I do now is help people to learn to navigate that and to help make the system better so that people don't have to work so hard. And to make sure that the moms and the whole family get supported because when things like this happen, your whole family seems to fall apart. You know, there were times I left the hospital and come home and flip my light switch and my lights were off because we forgot to pay the light bill. Not that we didn't have the money, we just were not thinking. And so some stuff just slipped through the cracks because we had 3 babies in the NICU. And so I'll give you a little bit of stats about how maternal and infant health fares in the United States, and it's very similar to North Carolina's stats. So Black women die in childbirth 3 to 4 times more likely than white women. 2 out of 3, so that's 66% of maternal deaths are preventable. And they found that through the maternal mortality review committees that a lot of states are having right now. North Carolina has one. They review the cases where women pass away, and then they look at those and find out, you know, where could interventions have happened, and if it had happened, would this person have survived? And so 2 out of 3 of those times, the answer was yes. This woman did not have to pass away. It was preventable. And then Black women with a college degree are 5 times more likely to die in childbirth compared to their white counterparts. So, you know, 2 educated women with college degrees, Black and a white woman, Black woman has a 5 times more likely chance to die in childbirth. And then as far as infants go, it's also a disparity. So Black infants die at a rate of 2 to 3 times more likely than their white infants before their first birthday. So those are the stats in the United States, and they're rising across the country. And so there's a lot of initiatives at the state and local level and national level to help repair what is going on, the bleed that's happening in these cases. And so then you hear my story. And so here are some of the partners that I personally work with on maternal infant mortality and patient engagement. We do a lot of talk about equity and what people need to be healthy, social determinants that have a impact on people in that maternal infant world. And so this is the consulting arm of my improvement work. So here is a little bit of history. So when you think about and you hear my story, you're going to hear some themes that resonate all the way back to before most of my family was even thought about. And it gives you a little bit of a backdrop as to the medical system and how we got to this place where we are now.
At the edge of Central Park in Manhattan, there's a bronze statue of a doctor named James Marion Sims, whose brilliant achievement carried the fame of American surgery throughout the entire world. He's the guy who created the vaginal speculum, an instrument gynecologists use for examination. He pioneered the surgical repair for fistula, a complication from childbirth, and became known as the father of modern gynecology.
Are you all able to hear that?
Yeah, we could hear it, but we couldn't see it.
Okay, it did say it stops. I'm gonna go
Okay.
back in.
edge of Central Park in Manhattan,
Let me know.
there's a bronze statue of a doctor named James Marion Sims, whose brilliant achievement carried the fame of American surgery throughout the entire world. He's the guy who created the vaginal speculum, an instrument gynecologists use for examination. He pioneered the surgical repair for fistula, a complication from childbirth, and became known as the father of modern gynecology. But that brilliant achievement was the result of a series of excruciating experimental surgeries that he conducted on enslaved women. In a lot of ways, Sims epitomizes the story of American medicine for Black women. It's a system that's failing them to this day. From infant mortality to life expectancy, the racial disparities in healthcare are staggering. The gulf between Black and white might be widest when we look at maternal mortality, with Black women 3 to 4 times more likely to die in connection with pregnancy or birth than white women. And that divide can be traced back to doctors like Sims, who contributed to a long, largely overlooked history of institutional racism in medicine.
Trying to understand a historical problem without knowing its history is like trying to treat a patient without eliciting a thorough medical history. You're doomed to failure.
That's Harriet Washington, a medical ethicist and author who chronicled the intersection of race and medicine in her book, Medical Apartheid. While many of the stark racial disparities in healthcare can be attributed to environmental and economic factors like access to good healthcare, studies show that minority patients tend to receive a lower quality of care than non-minorities, even when they have the same types of health insurance or the same ability to pay for care.
As African Americans, we've been abused for so long, consistently by the system. Why should we trust it? Why should we go to it when ill? And that's iatrophobia. That's a fear of the healer, inculcated by the behavior of those healers, unfortunately.
It starts with slavery. Doctors relied on slave owners for financial stability. They accompanied plantation masters to auctions to verify the fitness of slaves and were called in to treat sick slaves to protect their owners' investments. In 1807, Congress abolished the importation of slaves and in turn pushed Black women to have more children, to essentially breed slaves. Founding Father Thomas Jefferson later wrote, "I consider a woman who brings a child every 2 years as more profitable than the best man on the farm." Around the 1830s, the abolitionist movement led to the rise of what was called Negro medicine, or efforts to identify Black inferiority to justify slavery. And there were polygenists who tried to use both science and the Bible to find proof that races evolve from different origins. The 1830s also marked the beginning of recorded experimentation on Black women's bodies. One doctor performed experimental C-sections on slaves. Another one perfected the dangerous ovariotomy, or removal of an ovary by testing the procedure on slave women. In fact, half the original articles in the 1836 Southern Medical and Surgical Journal dealt with experiments on Black people. And then, of course, there was James Marion Sims, whose reputation is etched in history and on that statue in Central Park. Between 1845 and 1849, Sims began performing experimental surgeries on a 17-year-old slave named Anarcha. He eventually performed 30 operations on Anarcha and more surgeries on about 11 other female slaves. When his male colleagues could no longer bear to assist him in inflicting pain on the women, the slaves took turns restraining one another. Yet paintings depicting Sims, Anarcha, and other slave women presented a subdued version of his experiments. Even though anesthesia was introduced in 1846, Sims chose not to use it for his experimentation with slaves. His practices echoed one of the most prevalent and dangerous beliefs in medicine at the time, that Black people did not feel pain or anxiety. This book from 1851, titled The Natural History of Human Species, claimed the American dark races bear with indifference tortures insupportable to a white man. Studies released as recently as last year demonstrate that Black people are less likely to be treated for pain, particularly in the ER. There's even one from a children's hospital that found the same to be true for kids. And just this year, Pearson Education, a leading educational publisher, issued an apology and recalled nursing textbooks that included racist stereotypes, like this section that said Black people often report higher pain intensity than other cultures.
Well, what does it mean when you say that someone doesn't feel pain? Among other things, you're speaking about their humanity. These are all part of that suite of beliefs emanating from the 19th century that we still have not shaken off. Despite all our knowledge and sophistication, they're deeply ingrained.
Doctors like Sims might fit the Dr. Frankenstein stereotype, but they weren't outliers. Historically, Southern doctors who used Black bodies for troubling experiments were the norm.
It's a very common question. How can we judge our forebears? You know, those guys in the 18th century who practiced medicine in a way that appalls us today. You know, we think, how could you do that? I did not judge the practitioners based on our own ethics. I judged them based on the ethics of their time. It was not acceptable back then. We just did not hear from the people who protested against it.
After the Civil War ended, the 1900s brought a wave of immigrants to the U.S. It sparked a race panic and coincided with the birth of the American eugenics movement. One of the movement's key objectives was to reduce the childbearing potential of the poor and disabled. Leaders included birth control pioneer and Planned Parenthood founder Margaret Sanger, who eventually devised the controversial Negro Project, or family planning centers that pushed birth control in the Black South. It was a project that even garnered support from W.E.B. Du Bois, a founder of the NAACP, who wrote that Black people bred carelessly and disastrously. By the mid-1930s, more than half the states passed pro-sterilization laws, and often sterilization was forced. In 1961, future civil rights leader Fannie Lou Hamer went to the hospital to have a tumor removed, but was subjected to a hysterectomy without consent. The procedure, which rendered women infertile without their knowledge, was so common in the South that Hamer is said to have dubbed it the Mississippi appendectomy.
African American babies were no longer economically valuable. And African Americans themselves had gone from being a resource to a nuisance.
In June of 1973, the SPLC uncovered 100 to 150,000 cases of women who had been sterilized with federal funds in Alabama. Half the women were Black. In recent decades, women of color continue to be exposed to dubious reproductive health programs. In December 1990, the FDA approved a contraceptive called Norplant, and it was selectively marketed to Black teenagers in Baltimore schools.
You know, one of the current birth control methods now in the United States is Norplant.
Norplant fans like David Duke, the former KKK Grand Wizard, even introduced legislation to give women on welfare an annual reward of $100 if they agreed to get Norplant.
And it's time we start to encourage welfare mothers to be responsible.
That bill never passed, but the implant ignited a debate on whether long-term contraception, like Norplant that lasted 5 years, could be used as a form of social engineering when pushed to specific communities. Today, as we continue to lose Black mothers at alarming rates, a deeper look at the past may be a good step towards creating a more equitable healthcare system. Hi guys, thanks for watching. Of course, there's a lot more to the history of how the US medical system has mistreated people of color than we could fit in the video. Everything from the Tuskegee experiments to Jim Crow laws segregating hospitals. But we hope it starts to give some context to the racial disparities we see in medicine today. ProPublica has been reporting on the disparities in maternal.
So that gives you some context as to, you know, how things have evolved and how when you hear stories of women who have experienced challenges in childbirth, it rings true to hearing what happened when you think about what happened to people before us. When I hear stories that my mother and my sisters tell, it's, you know, they were very similar stories of not being listened to and you know, asking for assistance and not being able to get it. All of that stuff is what I hear and I still hear it from friends who have had children my age. When we talk about it, they have similar experience. So it's a long, deep-rooted issue. And now when I do talk to clinicians, you know, this is the way that I do it. I say it from the stance that no one goes into a hospital wanting to do harm, you know. The stories of, you know, things that Sims did and all of that, that was the intentional, I want to figure something out. And I'm not going to regard this person as a whole human while I do it. That is different than what's happening now. What's happening now is people have what's called implicit bias. So it is the unintentional act where people don't really see the person that they're in front of, they see a stereotype. So going back to my story, when you talk about an ambulance, coming up to pick me up, and they see me and they wanted to know what did I take, but they never went to my bed to see how much blood I lost. So that's the little part where you go, that's not typical behavior for a healthcare professional. Did they even recognize that? Probably not till this day. And the only way that people get this information is by sharing the stories and then helping people to realize, oh, wait a minute, I may need to pay a little bit more attention when I'm dealing with a person of color to make sure that I'm not doing that, because we all have a bias. That's how we're built. It helps us get through our day. We kind of make assumptions about how things are going to go. And that's really what it is. But it becomes harmful when you have a person that has the power of life and death in their hands and they're dealing with a person of color. That's where the challenge is. And so that's the work that I do with hospitals, is helping them to get those stories from their community and develop initiatives that can improve the healthcare system where they live. And so that's kind of a little bit. So the doula work, all of those things kind of work together into this nice little package. And I think I saw a couple questions. Oh, wow. Yeah. Most people don't know, most people don't know. Even
Yep.
women of color interacting with healthcare, they don't know, so I think it's not necessarily to scare, but I think people should be aware so that they can have some expectations and additional conversation with people.
There's a lot of kudos in there for bringing this topic to us, LaToshia, but one says, Caitlin wants to share the source of the video. She would like to have that source.
Absolutely. I have it. Oh, okay. So it's down in there. Let me grab it from my slides. I'll post it in the comments.
Okay, thank you. One of the things that you had talked about are implicit bias, which is that little voice in our head that is racist. And we all grew up with that because this is America. And and of course the tennis player, which I can't remember her name, she had blood clots and they didn't listen.
Williams.
Yeah.
Yeah.
Yes, they didn't listen to her, but she knew her body. And are you getting any pushback from any of the things you do, the education you do?
No, I think people are ready for it now, especially with everything that happened last year. Everyone is, and they're ready. I think everybody's kind of ready to do something. I don't think people knew what to do initially.
Mhm.
And so some of the initiatives that, I work on have been taking place from your work. So has been, I was the co-chair of the North Carolina Institute of Medicine's perinatal system of care. So for moms and babies, coming up with policy recommendations for our state to help improve care. I have worked with other states telling the story, and they decided that they were going to enlarge their tent. So instead of only having doctors and nurses at the meetings, they were also going to include EMS workers. They never thought to include them. I've also done work, so several things, and still going. I'm still working with research and policy and, large systems on this. So what you can do to help in North Carolina and all over, statistics show that women who they have a doula and they have a midwife, they fare better in childbirth because, if you're a person that knows how to get a baby out without a knife, you probably can do it more often than someone who has the knife option. So that is a thing. And so there are initiatives across North Carolina. One that I work with is called Equity Before Birth. And they do take donations and they are providing doulas to families who can't afford them. So they, in the triangle, do that work, and they also provide assistance to families who don't have paid family leave. In North Carolina, of course, and I know you know this, if you are out of work while you're having a baby, that's an unpaid time. And so some families with NICU babies, like what I had, and you got a baby in the hospital for 4.5 months, or 3 babies in the hospital for 4.5 months, and you're trying to manage, they would step in to help give you some financial support so that you're able to, you know, live during those times. And so that's a wonderful, wonderful organization.
Yeah. Veronica, you had a question in there. Would you like to address it to all of us?
I did. I just had a question as far as the educational piece of, do women understand that they have other options, like having someone like yourself, as opposed to just a regular doctor? I think that's huge, and especially when we have low income people. And that seems to be that socioeconomic piece where they don't understand that they do have other options. And so it's already biased against them, number one. So when you come in there with a problem, you know, they look at you like you are the problem. And so they don't really do the things that are necessary because of course, their stance is that, okay, you're taking advantage. Why are you here? You're having all these babies and we have to, taxpayers have to pay for them. That type of attitude. So they're not doing what they need to do to help you, you know, survive, so to speak. So I'm just wondering if, you know, this type of thing that you do, is that educating some of the women to let them know that they do have choices?
Yes, that is a challenge. But COVID was a huge help because everyone's afraid to go into the hospital. So they started to try and figure out what could they do? What were their options? And I have seen in this area all across the board, no matter the race, a large amount of people seeking out doulas and midwives. We do some education around that during maternal mortality, Black Maternal Health Week, which is April 11th through the 17th. I will have panels each night at 7 discussing what options are, what people should know, and helping to get the word out. And that happens all across the country during that week. But also, you know, just in being online, I've seen people find me that way and never know what it was. And some people want a doula and can't afford it. And then I have to find, you know, get this organization to pay for them. Some people are wanting to become doulas and they are, you know, making career changes during this time. So there's a lot of activity happening. But I wish there was something national that was in place to help get the word out.
Yes. And we have a doctor with us today, Charles, and he has an initiative. Would you like to share that with us?
Well, I don't know that I would call it an initiative. I'm a retired public health physician, moved down here from Alexandria, Virginia a few years ago. Spent many years in Alabama, so I have to say a lot of this sounded very familiar. There's a broader context to all of this. I know you know that. In terms of the social determinants of health that literally has been building for hundreds of years. It's been talked about a lot, and it's not only maternal and child health, but it's adult chronic disease, diabetes, hypertension, obesity, everything that's associated with that. So Mary Cam and I have had a couple of conversations about bringing a program to this club, maybe in late June, to have that broader discussion, maybe show the short video of the social determinants that's out there. I don't want to be the one that gives the talk myself. I think it's more credible if we get somebody in North Carolina to do this. I've got somebody in mind. He doesn't know it yet, but I've got somebody in mind. To be candid, without trying to start an issue, I would also like to bring this program to my home club, which is the Cary Rotary Club. Mary knows where I'm coming from on this, I think. I haven't decided yet if I want to do that. I think it should be done. And it's perhaps if I start going back to the club in person, I'll be a little clearer about doing that. So I think this was important to hear. I think Rotary needs to hear this in the broader context.
Yes, yes. When in the 70s, when I worked in the hospital,